Hello, welcome to this Introduction to safeMedicate webinar. This webinar is presented by Alex Weeks. We'll begin with an introduction to the background and research that underpins the safeMedicate suite of programs and its international impact. This first slide illustrates our 20+ year program of translational research. Healthcare translational research has been described as bench-to-bedside research due to original laboratory-based research being translated into a solution that impacts upon patients at the bedside. In the case of safeMedicate, our translational research began in 1992 with Professor Keith Weeks' PhD and his design, development and testing of a prototype dosage calculation program. The prototype then evolved through a series of translations that bridged the two gaps shown in the diagram and the development of the safeMedicate program that we'll be exploring today. More information about this translational research process can be found in the introductory paper in the Safety in Numbers series shown in the link. Currently, the safeMedicate program is being used by approaching 70% of universities offering healthcare programs in the UK and is informing the competence development of around 250,000 healthcare students and practitioners in 12 countries across 5 continents. This slide illustrates some of the universities and healthcare systems using the safeMedicate suite of programs in the UK. And safeMedicate is currently being used in the UK, Ireland, USA, Canada, Australia, Poland, Switzerland, Norway, Qatar, United Arab Emirates, Mauritius and Costa Rica. This slide highlights the impact of safeMedicate's translational research, which informed the competence modelling and rubric of the UK Nursing and Midwifery Council's revised essential skills clusters for medicines management. This inclusion became a regulatory requirement for all undergraduate nursing programmes from 2012 and provides a particularly strong example of both research directly influencing policy and of evidence-based regulation. We now move on to the drug dosage calculation problem. Turning to the scope of the medication error problem, this slide illustrates the startling figures for known error rates in the UK and the USA. It is largely believed that this is an underestimate of the true error rate. Significantly, inadequate staff training and assessment has been identified as a source of these errors. It is the correction of this failing education system that the safeMedicate environment is designed to address. There are 3 primary error types that healthcare students and practitioners commit. These are conceptual, problem understanding errors, calculation errors, and technical measurement errors. This slide illustrates an example of traditional chalk and talk methods used in the university classroom. These methods typically rely on the use of medication dosage word problems and abstract Formulae equations that are divorced from the reality of clinical practice. Our research, published in papers 2, 3, 4, 5, 6 and 7 of the Safety in Numbers series, explores how nursing students commonly find difficulty in understanding the language of word-based problems and formulae that are stripped of the meaning of the real dosage calculation problems seen in clinical practice. This commonly manifests itself as conceptual errors where the dosage equation is set up incorrectly. The example here illustrates how the conceptual error resulted in a 16 times overdose that in clinical practice would have had a very significant negative or even fatal effect on the patient's health. safeMedicate is designed to use authentic and interactive representations of the dosage calculation objects used in clinical practice, for example medication orders, ampules, syringes and so on. This sensitizes the student to the authentic competence requirements of clinical practice and supports diagnosis and rectification of conceptual errors at every stage of the education process. This slide illustrates how proceduralization of medicines administration in clinical practice can exacerbate errors. In this example, the healthcare practitioner asked, "We need aminophylline 50 mg. It comes as 250 mg in 10 milliliters, therefore we need to give 2 milliliters, okay?" The student replied, "Yes, 2 milliliters is correct." However, when taken to one side, the student didn't understand how the healthcare practitioner had arrived at 2 milliliters, but stated that they didn't want to look stupid by asking how it was done. This problem occurs due to healthcare practitioners carrying out invisible calculations and failing to externalize expert problem-solving techniques due to the sheer pace of clinical practice. We have effectively created a theory-practice gap that needs to be bridged. safeMedicate serves to bridge that gap. This slide illustrates how calculation errors are influenced by significant numbers of healthcare students and practitioners failing to possess the numeracy skills involved in medication dosage calculations. We illustrate how the safeMedicate multiple choice diagnostic numeracy assessment, or DNA, is designed to rapidly diagnose the possession of competence or common errors in the numeracy skills required to calculate dosage calculation problems. Each MCQ consists of a typical numeracy problem encountered in medication dosage calculations, and a choice of 4 answers. The correct answer, the 3 most common errors recorded during assessments of over 2,000 prospective nursing students, and a don't know answer, which is included to prevent forcing the student to guess an answer when they do not possess the necessary numeracy skills to solve the problem. We illustrate here one example from the DNA that illustrate common errors that we're sure many of you who teach this skill will be familiar with. Here we have a typical problem requiring the conversion of a 2/5 fraction to its decimal equivalent. First we have the correct answer, 0.4. Next, an arithmetical operation error where an incorrect operation involving the division of the fractional denominator, 5, by the fractional numerator, 2, equals 2.5. Next, the same arithmetical operation error coupled with a computation error where division of 5 by 2 results in an answer of 2, remainder 1, or 2.1. And finally, a computation error where failure to insert a decimal point between the 2 and the 0 results in an answer of 4. Errors of this type are commonly caused by mathematical drop stitches that result from a failure to understand a fundamental mathematics concept during primary and secondary school education. These problems commonly persist into adulthood, and it is critical to diagnose numerical errors early in the health professional education process so that support mechanisms can be mobilised to support picking up of the drop stitch, correction of the error, and prevention of further medication dosage calculation errors. This slide illustrates examples of typical technical measurement errors committed by students during objective structured clinical examinations, or OSCEs, undertaken as part of a counterbalance programme of research reported in Paper 5 of the Safety in Numbers series. The measurement of medication doses is the critical endpoint of the medication dosage calculation process and centres on the selection of an appropriate measurement and administration vehicle, for example a syringe, and the measurement of the calculated dose and measurement unit, for example 5 millilitres. The examples shown here illustrate the inappropriate selection of a medicine pot to measure a small volume that should have been measured in an oral medicine syringe, and the mismeasurement and failure to dispel air bubbles and air boluses from measured doses of medication. Students provided anecdotal stories of having very limited opportunities to measure doses of medication in clinical practice, and hence the manifestation of these technical measurement errors. Other common technical measurement errors amongst both students and registered practitioners includes the inappropriate selection of volumetric syringes to measure insulin. Undetected and uncorrected errors of this type can have very significant negative or even fatal effects on the patient's health. safeMedicate is designed to use authentic and interactive representations of these syringes and IV pumps, etc., used to measure doses and administration rates in clinical practice. This sensitizes the student to the authentic competence requirements of clinical practice and supports diagnosis and rectification of technical measurement errors at every stage of the education process. So, think in patient safety. This means that any undiagnosed or uncorrected conceptual, calculation, or technical measurement error will result in a medication dosage error and potential harm or fatality for the patient. The next set of slides illustrates the safeMedicate education solution. This competence model lies at the heart of the safeMedicate learning and diagnostic assessment environment and consists of the three essential elements of the medication dosage calculation process that need to be mastered to undertake safe practice. First, conceptual competence. This involves demonstration of conceptual understanding of the clinical dosage problem to be solved. This requires identification and extraction of essential numerical information and measurement units from clinical medication objects such as medication orders and medication container labels, and then accurate setup of a dosage calculation equation. Next, calculation competence. This involves demonstration of the accurate calculation of a numerical value and measurement units for the dose to be administered. Finally, technical measurement competence. The emphasis here is on demonstration of the accurate measurement of the dose or rate of the medication to be administered. This involves the ability to select an appropriate administration vehicle, for example a syringe, and accurate measurement of the dose or rate of medication to be administered to the patient. The white intersection at the center of the model represents the integration of all three elements of the medication dosage calculation process. Further information on the safeMedicate competence model can be found in papers 2, 3, 4, 5, 6 and 7 of the Safety in Numbers series. This slide focuses on the key features of the mathematics education model that informs the design of safeMedicate authentic learning and diagnostic assessment environments, situated cognition and competence modelling. This focuses on the premise that knowing or cognitive competence in dosage calculation is inseparable from context-based know-how and skilled performance or functional competence. The safeMedicate team work with expert education and clinical practitioners to capture real-life expert dosage calculation problem-solving practices and recreates them in an authentic and interactive virtual clinical environment. Constructivist perspective. This focuses on supporting healthcare students and practitioners to immerse themselves in the virtual clinical environment and to actively engage in constructing, building, and developing competence in medication dosage calculation problem solving. Cognitive apprenticeship. This focuses on a structured apprenticeship-based education model that supports stepwise modelling, supported learning and coaching, diagnostic assessment, and feedback and reflection on medication dosage calculation competence development. Cognitive style in mathematics. This focuses on the premise that people manifest a range of mathematics learning styles. Cognitive styles vary in the processes used to solve mathematics problems. There is no right or wrong way to solve a dosage calculation problem, and safeMedicate environments support students in the use of a range of cognitive styles and approaches to solving dosage calculation problems. Finally, non-threatening learning and assessment environments. This focuses on recognition that many people experience maths anxiety or mathophobia. Factors that influence maths anxiety includes mathematics that has a lack of relevance to real life, presence of an authority figure, an emphasis on timed tests, a perception of feeling foolish in front of others, abstract and ambiguous mathematics language, and mathematical drop stitches. safeMedicate addresses the problem of maths anxiety by the presentation of an authentic virtual environment relevant to the real world of dosage calculation, self-paced learning that accommodates for individual learning styles, and a unique approach to supporting confidence development through bridging of the theory-practice gap. Further information on the key features of the mathematics education model can be found in paper 3 of the Safety in Numbers series. Prior to exploring the authentic features of the safeMedicate environment, we will take time out for you to explore and evaluate your own learning style in mathematics and the implications for the teaching and learning of medication dosage calculation skills. The test of cognitive style in mathematics was first described in 1986 by John Barth, Stephen Chin, and Dwight Knox. One example from the test is illustrated here. To get an idea of your cognitive style, take a few minutes to calculate the sum of the numbers on the screen. When you've finished the calculation, we'll explore the next slide and compare your problem-solving approach with those illustrated. If you started at either end of the row of numbers and added the numbers in sequence to arrive at a solution of 45, then this is an indication of an inchworm style. An inchworm is a looper caterpillar that arches its back and propels itself along inch by inch. This approach is analogous with a serialist learning style, where the person typically solves problems in a step-by-step sequence using pencil and paper. If you scanned the sequence of numbers and recognised that you could group the numbers together in 4 groups of 10 plus 5 to arrive at a solution of 45, this is an indication of a grasshopper style. The grasshopper makes conceptual leaps, and this approach is analogous with a whole list learning style, where the person prefers to see the whole problem before deciding on a problem-solving strategy, and then typically mentally scans and rearranges the number sequence to simplify the problem. Another example of this process is scanning the number sequence and recognising that in an odd number sequence of 3, 5, 7, 9, 11 numbers, when reading from left to right and multiplying the centrally located number by the last number, you arrive at the sum of the sequence. Try it for yourself. If you adopted a bit of both of the inchworm and grasshopper strategies as illustrated, this is typical of an integrated style, where the person uses a combination of approaches to solve the problem. Beyond undertaking this exercise for the benefit of your own interest, the concept of cognitive style in mathematics is relevant to the teaching and learning of medication dosage calculations. The next slide explores this further. This slide illustrates the distribution of UK and USA nursing students' cognitive style in mathematics. This highlights the variation in learning style across the 2 samples and how each of the 3 groups of students would typically use a different approach to solving a mathematical problem. From a health professional education perspective, teachers will typically use their own learning style approach to demonstrate how to solve a dosage calculation problem, and this can result in a lack of understanding amongst students who manifest a different learning style. safeMedicate addresses this problem by supporting the use of inchworm, grasshopper, and integrated approaches to solving dosage calculation problems. We now move on to safeMedicate competence and error diagnosis. This slide illustrates the diagnosis of a correct answer and demonstration of conceptual, calculation, and technical measurement competence. This slide illustrates the diagnosis of a primary conceptual or equation setup error. This in turn has led to a secondary calculation and technical measurement error. Also, please note the orange calculator feedback bar. The built-in safeMedicate calculator records every keystroke entered, so if an error is made whilst using the calculator, this can help to diagnose those errors. This slide illustrates the diagnosis of a primary arithmetical operation calculation error, where the student has incorrectly divided the numerator into the denominator and has subsequently committed a secondary technical measurement error. This slide illustrates the diagnosis of a primary technical measurement error, where the student has misunderstood the design of the volumetric syringe and incorrectly measured the 3 ml dose volume using the trailing edge of the syringe plunger. And finally, this slide illustrates the diagnosis of a primary technical measurement error caused by the conceptual misunderstanding of the design of volumetric and insulin unit syringes. Here the user has incorrectly selected a volumetric syringe to measure and administer insulin, resulting in a 10-fold error. This slide illustrates the indicative content of the safeMedicate phased developmental curriculum map employed in UK undergraduate and postgraduate healthcare professional programs. The phased competence assessment and remedial skills development program has also been specifically tailored for use in pre-employment recruitment assessment and skills audit programs in hospitals and other healthcare organisations. Country-specific variants of the UK curriculum and clinical skills audit programs are available for North America and Australasian university and healthcare systems. This slide illustrates the rubric assessment framework for the first progression point. Currently, here in the UK, this is at the end of year 1 of an undergraduate healthcare program. Using a hierarchical rubric such as this, we can ensure that all complexity levels and modes of administration are assessed. In this rubric, tablets and capsules, oral liquid medicines and injections are assessed at the unit dose, subunit dose, multiple unit dose and conversion of SI unit complexity levels. This slide illustrates the rubric assessment framework for entry to the register in the UK. This assessment framework can also be used in healthcare organisations as the start point assessment when auditing and testing staff, as this is currently the minimum standard required at the point of registration in the UK. In this rubric, building on the construct and content of the first progression point assessment framework, we introduce complex calculations and also IV infusion mils per hour and drops per minute calculations. Please note that these are IV infusions involving only crystalloid, colloid and blood products. In assessments, 100% competence achievement must be measured in a stratified hierarchical rubric. This slide illustrates the fallacy of an 80% competence achievement level. Here, a user can achieve 100% in the unit dose, sub and multiple unit dose and conversion of SI unit level problems, whilst getting all of the complex arithmetic problems wrong and scoring 80% on this assessment. If this user was deemed competent and was faced with a similar complex arithmetic problem in practice, they are highly likely to commit an error. This slide illustrates a selection of the administration features available through safeMedicate, including automatic setting of assessments, automatic diagnostic assessment and marking of assessments, review and tracking of user feedback, review of user records, review of institution usage, and administration resources. For more information on these features, please see our administration how-to videos or attend one of our how-to webinars. Information on when these are scheduled and how to sign up for these can be found on the safeMedicate website. This final slide highlights the key benefits of using safeMedicate. This centres on safeMedicate program design and development underpinned by a 20+ year program of international translational research. The impact of safeMedicate research and development has informed the UK Nursing Regulator Essential Skills Clusters. This is currently informing the curricula of approximately 70% of universities in the UK offering healthcare training programmes, and the competence development of around 250,000 healthcare students and practitioners in 12 countries across 5 continents. safeMedicate provides a fully automated learning, diagnostic assessment and examination setting and marking facility that significantly reduces faculty workload and logistical support requirements. And finally, an extremely cost-effective curricular innovation resource and clinical audit tool that represents unbeatable value for both university and clinical healthcare organisations. If you have any questions or queries, please let us know. Alternatively, you can contact us by using the details shown on screen. Please note that the telephone number is for administrators only. Please sign up for our How-To and ABC webinars for more information on safeMedicate and its features. Thank you very much.